Good afternoon and welcome to the CDI Toolkit for Post-Acute and Long-Term Care Settings. My name is Brandon and I'll be your operator for today. At this time, all participants are in a listen-only mode. Later, we will conduct a question and answer session during which you can dial *1 if you have a question. I will now turn it over to Kathy Nichols. Kathy, you may begin.
Thank you. Hello, everyone. This is Kathy Nichols with Stratus Health, the Minnesota organization that's part of Lake Superior Quality Innovation Network, or the Lake Superior QUIN. Lake Superior QUIN represents Minnesota, Michigan, and Wisconsin under the Centers for Medicare and Medicaid Services Quality Improvement Organization program. I would like to welcome you to this educational session entitled Long-Term Care Facility Clostridium difficile Toolkit. As Brendan said, all the lines will be muted during this webinar. However, after the presentation, we'll have time for questions and answers, so please make a note of any questions that may come up as you listen. We'll have the operator tell you how to ask your question over the phone when we end, or you can go ahead and place your question in chat at any time. I'd like to introduce our two speakers for today, Maria Bai and Janet Littleberg. Maria Bai is an epidemiologist at the Minnesota Department of Health and is coordinator for the state's Clostridium difficile surveillance program. She received her BAs in biology and communications from the University of Minnesota and her MPH from Emory University. Also joining us today is Janet Littleberg. Janet received her MPH at the University of Minnesota. She's worked as a planner and epidemiologist at the Minnesota Department of Health in the HAI's Antimicrobial Resistance Unit. She works with state leaders to build coalitions of providers and partners to decrease HAI. Maria, I will now turn it over to you.
Thanks, Kathy, and thanks everyone for tuning in today as we talk about the Long-Term Care Facility Toolkit developed by the Minnesota Department of Health. 1 minute here. Before we begin, I just wanted to briefly introduce ourselves again. I'm Maria Bai. Janet Littleberg is also joining me today, and our jobs are basically all C. diff all the time. So we are glad that you're interested in the work that we're doing. This toolkit was many years in the making. For a long time, there's been a gap in C. diff resources. There are many great comprehensive resources for acute care settings, including the Safe from CDI Toolkit and APIC's Guide to the Elimination of C. diff in healthcare settings. Some of these principles can be applied to long-term care facilities. However, long-term care facilities differ in many respects from acute care facilities, so not everything is transferable. Residents are not just in the facilities for a short stay, like in hospitals, but they live there. It's their home. Because of this, the way that we handle C. diff is not exactly the same as we do in acute care. We want to limit the negative impacts on their social and emotional health and reduce stigma. So, in an effort to address this need for information tailored to a non-acute setting, we pulled together resources from APIC, SHAE, the CDC, other state health departments, and other organizations to come up with a comprehensive set of tools for long-term care facilities. We went through multiple rounds of feedback with the APIC Minnesota Long-Term Care Facility Subcommittee and refined it from there. Our hope is that facilities can use this toolkit to empower their staff and to make them feel confident in handling C. diff cases. So, first things first, how do you access this toolkit? You can do this in two different ways. You can go to the direct link, which is listed here, or you can go to the MDH website and type C. diff Toolkit into the search bar. The toolkit will be the first link that pops up. One of the pieces of feedback that we received from the APIC Long-Term Care Facility Subcommittee was that they wanted a collaboration or a collection of standalone resources that they could pick and choose from rather than having one giant book-like document. So we broke the toolkit up into 6 different themes that contain multiple links that can be individually accessed. That way, facilities can print off 1 or 2 pages instead of 200 pages. Each theme is an important component of identifying and controlling C. diff cases. These themes are prepare, detect, contain, clean, prevent, and educate. During our presentation today, Janet and I will highlight some of the resources in each of these themes. So we'll start with prepare. As our old friend Ben Franklin said, by failing to prepare, you are preparing to fail. The resources in this section will help your facility prepare for C. diff cases, so you're ready to coolly and competently handle them when they come. We don't want to overwhelm you with information and don't have enough time to cover all of the resources in detail, so I'll just choose some of the links to highlight in each of the sections. I'll specifically talk about the resources in red. I encourage you to check out the toolkit yourself to see the other fantastic items included in it that we don't cover in this webinar. For the prepare section, I will not be covering the C. diff background or the C. diff response algorithm. The first item I wanted to focus on is the early identification and containment assessment checklist. This assessment is split into two sections: knowledge and competency, which tests your staff's awareness and application of C. diff practices, and infection prevention policies and infrastructure, which assesses whether your facility has proper policies in place. Each of these two sections has questions about early identification and rapid containment. The next resource revolves around making a C. diff prevention team. Many facilities overlook this, but really, it's a crucial step. Preventing and managing C. diff requires coordination among many stakeholders. Having an interdisciplinary team facilitates a swift and thorough response. For instance, you may have a knowledgeable and competent medical staff in place that can treat and take care of a C. diff case, but if environmental services isn't educated on how to properly clean the room, or if they aren't notified that there's a C. diff case, there is a potential for further transmission. Or if you have a wonderful infection prevention personnel, but a pharmacy that doesn't buy into antimicrobial stewardship, you can control cases once they pop up, but you're not doing everything you can to prevent them in the first place. We really like to promote the next document, which is an example C. diff prevention and control policy. Many facilities say that they want to have a C. diff policy, but they don't know how to get started writing one or what they should include in one. It can be a pretty daunting task. So this document is an editable Microsoft Word document that is completely customizable. Facilities can use it as is and merely plug in their facility name, or they can modify it to better line up with their patient population and workflow. Our example policy covers a variety of components, including contact precautions, therapy, laundry, and other prevention activities. The second theme in our toolkit is detect. In order to control C. diff, you have to be able to quickly and accurately detect it in your facility. Again, I'll only touch on the resources that I highlighted in red here, but you should also check out the detection and surveillance self-assessment, surveillance information, and infections tracking tool. MDH has created 5 algorithms that explain various steps of preventing and controlling C. diff. We try to make them easy to use and in a format that can be posted on the wall or in an employee handbook. This algorithm explains when to test a resident for C. diff, how to test them, what to do while the results are pending, and what to do when the results come back. Not following recommended testing guidance can lead to over-testing, which can falsely inflate C. diff rates in your facility. You may put residents on contact precautions unnecessarily. This is because in a non-outbreak setting, up to 20% of long-term care facility residents can be asymptomatically colonized with C. diff, which means that the bacteria is present in their gut, but it's not making them sick. In an outbreak, it can be as high as 50% of long-term care facility residents that are asymptomatically colonized. To prevent over-testing, we provide testing recommendations and specimen rejection criteria for your lab. In order to avoid an incorrect diagnosis, if a resident has not had 3 or more unformed stools in a 24-hour period, they shouldn't be tested. Additionally, repeat tests should not be ordered, and formed stools should not be tested. You can use the next resource, the Bristol stool chart, to characterize stool before sending it into the lab. So your facility has prepared for a C. diff case, and because of the protocols you have in place, you have detected one. Now what? That leads us to our third theme, which is contain. We have a wealth of resources in this topic, but again, we'll only touch on some of them. Contact precautions can help prevent the spread of C. diff. Facilities are often unclear about the best practices for doing this, though. So we have an algorithm that guides facilities through initiating, continuing, and discontinuing contact precautions. Contact precautions include wearing the proper personal protective equipment, or PPE. We've included an assessment that your staff can take in order to evaluate their PPE knowledge and practice, as well as easy-to-follow directions for donning and doffing PPE. Even if staff are wearing the correct PPE, but they're donning and doffing incorrectly, they could still be putting themselves and other residents at risk. When a resident transfers to your facility from another one, whether it's another long-term care facility or an acute care facility, you won't know whether to use contact precautions or not if the proper communication channels are not in place. Likewise, you should prepare facilities you're transferring residents to by telling them about infections that your resident currently has. Disinfection control transfer form is a concise way to communicate with other facilities and ask for information like current infections that the resident may have, what their symptoms are, what PPE is needed for these infections, and whether you should be concerned about multi-drug resistant organisms. That way, you and other facilities will not be caught by surprise. If a resident has C. diff, you want to try to isolate them as much as possible while they're at their peak infectiousness. Room placement is part of these isolation precautions. Ideally, the resident would be in a private room with a private bathroom, but that's not possible for every facility. This room placement algorithm walks facilities through primary and secondary considerations for rooming residents and provides first, second, and third choices for cohorting residents. It also gives guidance on how to bathe residents who have C. diff. The last section that I'm going to cover before Janet takes over is cleaning. C. diff is a spore-forming bacteria, which means that it can persist on surfaces for months. It's also resistant to many types of commonly used cleaners. Because of this, making sure that your facility is cleaning and disinfecting properly is an essential way to managing C. diff. Again, we have tons of great resources in this section, but I'll just touch on 3 of them. Staying on top of C. diff is everyone's responsibility. The environmental cleaning and disinfection algorithm explains cleaning responsibilities for every shift, as well as what's included in the terminal cleaning. Since C. diff is spread through the fecal-oral route, a key place to focus cleaning is in the bathroom. This algorithm also includes good general recommendations like cleaning from clean to dirty. Probably the question I get most at the health department is, what cleaners are effective against C. diff? The EPA has prepared a handy list with the not very exciting name of List K that includes all the antimicrobial products that are effective against C. diff spores. Most people know that they can use bleach, but there are actually 2 other chemistries that are registered for hard surface disinfection. They are peroxyacetic acid and sodium dichloroisocyanurate. And these are approved choices for eliminating C. diff. The last resource that I wanted to talk about in the clean section is our C. diff cleaning audit tool. It's huge, 11 pages long. You can use this to make sure staff are cleaning the high-touch and easily forgotten places in your facility. It also includes a 27-question assessment to evaluate general cleaning practices and protocols. And now I'll hand it over to Janet for the final 2 themes.
Thanks, Maria. The next section of the toolkit, let's see, I must have to click on it here. The next section of the toolkit includes information on prevention of C. diff. We talked about preparing our facility for caring for patients with C. diff and how to detect, contain, and clean the facility, but this section will be discussing how to decrease the chance the residents will get C. diff. There are several risk factors for C. diff. The most significant modifiable risk factor is the use of antibiotics. The use of multiple antibiotics or taking long courses of antibiotics disrupts the normal flora in the intestinal tract. This gives C. diff spores the opportunity to thrive. This section covers assessment of your facility and criteria for when to prescribe antibiotics, antibiotic stewardship programs, and treatment of Clostridium difficile. To prevent C. diff, it's important to assess the practices within your facility. At the start of your program and periodically throughout the program, this can reveal gaps in the C. diff and improve C. diff reduction efforts. The assessments in the toolkit evaluate the effectiveness of your efforts and recommend changes. The C. diff assessment tool covers 3 areas. The first is knowledge and competency. The second is the assessment tool looks at the policies and infrastructure within your facility. And finally, the assessment tool looks at monitoring practices. It asks questions like, is there training that allows staff to recognize changes in resident status that indicate a new infection? Does the training include resources and staff they need to help guide decisions about when to suspect a resident has an infection or needs an antibiotic? Does your pharmacy provide monthly reports of antibiotic use for the facility? Do prescribers get feedback on their prescribing practices? Does the lab reject stool samples that aren't formed? These are the kinds of questions the assessment asks, and it gives you a chance to look at is this different ways that you could improve your facility's practices. One of the things in the prevention piece of it is prescribing. Monitoring prescribing practices is an important part of C. diff prevention. Many studies have shown that antibiotics are overused. The toolkit recommends limiting the use of antibiotics when they're not needed and minimizing the frequency, duration, and number of antibiotics prescribed. The appropriate use of antibiotics can improve the outcomes for residents who need antibiotics and prevent the unintended consequences of antibiotic use, such as side effects, the development of antibiotic-resistant bacteria, and replacement of normal bacteria with the bacteria that cause infections, such as C. diff. It's important to prescribe the right antibiotic for the right reason. The toolkit includes Loeb's minimum criteria for the initiation of antibiotics in the resident's long-term care facility. The Loeb's criteria guide providers' antibiotic prescribing practices in nursing homes, and the MDH toolkit provides a 2-sided card with the Loeb's criteria that can be printed, and the criteria are for the respiratory tract infections, UTIs, fever, and skin and soft tissue infections. The guide helps frontline caregivers and prescribers in knowing when to be concerned about an infection in a resident and what clinical and patient information is needed to determine whether a prescription is needed. Prescribing practices are a part of overall antibiotic stewardship program. And that leads us to the antibiotic stewardship program. The C. diff toolkit does not go into much depth about antibiotic stewardship because MDH offers a whole different toolkit specific to long-term care stewardship, antimicrobial stewardship. I just want to take a moment to encourage you to check out the antimicrobial stewardship program toolkit. Antimicrobial stewardship can be very abstract, and this toolkit was developed in collaboration with several long-term care partners to offer concrete tools that help long-term care start and maintain an antibiotic stewardship program. I've provided a link to this toolkit in our slides, and our website has an abundance of resources related to stewardship. So I invite you to check those out. The core tools include action steps and strategies for implementing antibiotic stewardship and an auditing tool. There are links to educational training, posters, and fact sheets. There's clinical decision-making tools such as algorithms for deciding whether to treat C. diff, UTI, and fever. There are tools for nursing communication, and we've had a lot of positive feedback on our infection surveillance line list. It's used to track infections and antibiotic use. So I encourage you to check that toolkit out as well. The last section in the prevention section of the toolkit is C. diff treatment. We're talking about prevention of C. diff, and it might seem a little strange to include C. diff treatment in this section. But the reason it's important to talk about C. diff treatment is it's a strategy in prevention because C. diff reoccurs in about 20% of the cases. So it's important to actually talk about how do we treat the patient so that it doesn't reoccur. Surprisingly, the recommendation is to first treat C. diff with antibiotics such as metronidazole and vancomycin or fidaxomicin. But when C. diff reoccurs the first time, it's usually treated with the same antibiotic again. But for residents who have had more than one reoccurrence, there's a newer thing, fecal transplants from healthy people that has shown a great deal of success. So that's been added as a recommendation recently. Oops, I think I got it. The final section of the toolkit focuses on education. The education link has several resources for healthcare workers, environmental cleaning staff, residents, and their families. I'll just touch on a few of the resources, starting with the Facility Education Activities Assessment Tool. Not PG. There we go. The education link has several resources for the healthcare workers, environmental cleaning staff, residents, and their families. I'll just touch on a few of these resources. The first one I'll touch on is the current Facility Education Activities Assessment Tool. It looks at things like, it gives you the chance to look closely at what education and training is going on within your facility and compare them to best practices. It looks at things like, is there C. diff prevention education for all healthcare workers? Is there cleaning and disinfection education for nursing and support staff? Is there competency testing for environmental services? Those are the kinds of things that it looks at for in the education, assessing the education. The education section also refers to answers about common C. diff questions, and that's actually a link to the CDC website, so I won't be covering that. C. diff precautions may be confusing for residents and their families and friends. Maybe the instructions and the care they received in the hospital were different than the care in the nursing home. In writing this section, we tried to keep in mind that this is their home. We try to keep the information basic because some haven't even been given any information about what is C. diff and how it's spread and what staff and visitors can do to prevent the spread. So that's what we've included, a sample template letter that will describe it to the patients, visitors, and their friends to help clear up some of the confusion. The next section is the environmental cleaning education. Each employee working in environmental services should be trained upon hire annually and when non-compliance is observed. Also, all healthcare workers who provide direct resident care should be educated about their responsibilities in cleaning and disinfecting medical equipment and environmental services. Each should know and understand their roles and understand the difference in their positions and who's cleaning what piece of equipment. So the toolkit describes the topics to be covered in training. Topics such as, why is cleaning so important? What's the proper use of PPE? Which cleaning products should be used for each task and in what concentration? Who's responsible for cleaning what equipment, the furniture, and the room? The toolkit prompts you on several topics and ensures that training will be comprehensive. Finally, the toolkit includes references from the CDC, APIC, ISDA, and SHE. These organizations that provides the background you will need to set up your program. So we've included links to several of their guides. Now I'd like to just take a moment to thank Kathy Nichols from Stratus Health and Dr. Stacy Holzbauer, APIC Long-Term Care Committee, Medora Whitwer, and Tori Witten. They were all contributors to the toolkit, and we appreciate their time and their efforts very much. And thank you.
Thank you very much, Janet and Maria. Thank you for sharing on the toolkit. I've been spending some time looking at it, and I am very impressed with how comprehensive it is and how easy and clear the tools are in the toolkit. You've covered everything, and it's a wonderful asset to our long-term and post-acute care facilities. So thank you so much, and thank you for walking us through it and sharing this information now. We've now got time for questions or comments for Janet and Maria. Brandon, can you remind our participants how to get in the phone queue for questions or comments? We also have chat open, so if you prefer to put your question into chat, we can monitor that for you also.
Thank you. We'll now begin the question and answer session. If you have a question, please press star 1 on your telephone keypad. If you'd like to be removed from the queue, please press the pound sign or the hash key. There may be a delay before the first question is announced. If you're on a speakerphone, please pick up your handset first before dialing the numbers. Once again, if you have a question on the phone, please press star 1. And we're standing by for questions.
Thank you. In the chat, we do have the link to finding the slide handouts. We did send them out in emails to everyone who had registered and to other participants in the Quality Care Collaborative, so hopefully you have found them and access to them. We have one comment from Stacy, who says that they've been using the interfacility form, the transfer form, but have a hard time getting the hospitals to return. So they've been calling and asking the questions rather than faxing it, which I think is a great solution to get the communication that you want. I like the transfer form and think it gives some real comprehensive guidance to the information that you need.
Great. Thank you so much for sharing that.
All right, at this time, it looks like we have no questions on the phone.
Okay, we're starting to get some questions in chat. We've got one from Corey. For some reason, she can't find the access link to the forms, the toolkit, and did not receive an email with the information. You can find the slide handouts, which includes the link, so you can use that above. We'll have that put in again into, there it is down below, so you should be able to access it. If you can't, please reach out to myself, and I can get that link for you. A question for you, Maria and Janet. Can you describe some effective strategies for collaborating with acute care?
Great question. We've been kind of mulling that over with some of the. We've actually had acute care and long-term care talk about this at our team conferences, and that does seem to be something that we're always looking for ways to clarify the communication between the two. And I think the main thing is to open up that communication with the infection preventionists at the acute care hospitals and ask them, how can you improve this? How can we make this form that I've got here work for us, because we're not getting the information we need? And I think it's getting to know those people and making that acute care infection prevention a part of your team, so that, or, on board with you, and maybe meet with them on occasion just to talk about infection status and how to make that a priority when you're transferring a patient.
Yeah, thank you, Janet. I think those are great suggestions. Any way that you can open up that communication. I think oftentimes people forget about the infection preventionist at the hospital, that someone has that responsibility and should be able to assist you with getting the information that you need, as well as helping with those communication strategies. If anyone else has suggestions for how they've worked with other acute care settings, please put your comments in chat or get into the queue. Another comment in chat is, could I get a printed copy of the toolkit sent to me? We don't have printed copies, Tanya. I think if you find the link in the slide handouts that's listed in chat, you should be able to print out a copy of the toolkit or the sections that you want. Brandon, anyone else have questions?
No, it looks like no questions on the phone right now.
All right. I think we will conclude this educational session for today. Thank you again, Maria and Janet, for speaking with us. As you exit from this webinar, a window will open to a short evaluation. There's also a link being placed to the evaluation in the chat box right now. Please take a minute to provide us feedback on today's session. We use your feedback as we prepare education, tools, and resources to meet your needs. After completing the evaluation, you will be able to print out a certificate of attendance for this session. This session was recorded and will be available on the Lake Superior Quinn website in about 2 weeks. Thank you all for participating, and thank you again, Janet and Maria, and everyone have a great afternoon. Bye.
Thank you.
Ladies and gentlemen.